We'll get started. So good morning, everyone, and welcome to today's webinar, Integrating Clinical Pharmacy Services with an FQHC for Health Center Staff and Clinicians. My name is Rima Naik, and I'm the Program Manager for Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to healthcare for all, especially the underserved and underinsured populations. For more information, you can visit us at nvpca.org. Before we get started, I would like to go over some logistics and housekeeping items for today's webinar. Please type in your name and organization into the chat box. It's really nice to see who from our community is with us today. During the presentation, please make sure to mute your phone or computer so that we do not have feedback noise or background noise. Also, please be sure not to put your phone on hold or we will hear your background music. You'll have the opportunity to submit your questions to the presenters by typing in your questions into the chat box. You may send in your questions at any time during the presentation, and questions will be collected and addressed during the Q&A session of our training. Today's session will be recorded and will be available to participants. I would now like to introduce both of our speakers today. We have Nitochi Adeolokun and Jennifer Wheeler. So Nitochi was born and raised in Nigeria. He came to the US in his early teenage years. He was a chemistry major at Idaho State University, and it was involved heavily in organic chemistry research prior to attending pharmacy school. He later moved to Reno in 2015 to complete his final year of pharmacy school and graduated in 2016 with a Doctor of Pharmacy. He began working at Community Health Alliance as an intern pharmacist and enjoyed serving the patient population and expanding its knowledge on diabetes. Shortly after graduation, he accepted a full-time position at Community Health Alliance, and he's achieved board certifications in both ambulatory care pharmacy and advanced diabetes management. We also have Jennifer Wheeler here with us today. Jennifer has been practicing pharmacy since 2002, starting as a technician and eventually graduating pharmacy school. Since joining CHA in early 2015, she has discovered a passion for working with underserved populations. In 2017, she earned her CDE, which allows her to provide personalized diabetes care for those in need. So with that said, I'm going to hand it over to Nitochi and Jennifer to lead us off in this conversation. Thank you.
Okay, so we have to share our screen. So we are sharing our screen, correct?
So integrating clinical pharmacy services within an FQHC. The objectives for this discussion is to define who a clinical pharmacist is, how to earn the trust of the clinical team, the challenges that we have faced and that we are currently facing, some of the breakthroughs that we've had since starting our program, and then the future goals that we have for our program within our organization. Community Health Alliance. This is a picture of one of our 7 medical sites. This is the Wells location. We are located within the Reno-Sparks area in Nevada. We have 2 in-house pharmacies. One is at our Wells location. One is located in our Sparks facility. We are the medical home for nearly 30,000 patients and have greater than 90,000 medical encounters annually. We employ more than 250 people. Our mission is to provide quality healthcare to everyone. Our services that we offer here include preventative medicine, clinical and retail pharmacy, dental services, behavioral health, women's health, WIC and nutrition counseling. So who is a clinical pharmacist? Clinical pharmacists work directly with physicians and other healthcare professionals and patients to ensure that the medications prescribed for patients contribute to the best possible outcomes. And what is it that we do? So we will meet with patients. We assess the status of the patient's health problems and determine whether the prescribed medications are optimally meeting the patient's needs and goals of care. We are able to work with patients and change their medications based off of different barriers that they may encounter, such as cost, insurance not covering medications, prior authorizations, medications that are difficult to take around their skin. The appropriateness and effectiveness of the patient's medications. We recognize untreated health problems that could be improved or resolved with appropriate medication therapy, and consult with the patient's physician and other healthcare providers in selecting medication therapy that best meets the patient's needs and contributes effectively to overall therapy of goals. Proof that clinical pharmacists actually do good work. There's a lot of research going on in this area. And as pharmacists, we're always trying to prove that we are quality members of the healthcare team. And since we are a non-reimbursable provider. So adding pharmacists to primary care teams reduces predicted long-term cardiovascular events in type 2 diabetic patients without established cardiovascular disease. And adding pharmacists to primary care teams increases guideline concordant antiplatelet use in patients with type 2 diabetes. And the last one that we looked at was pharmacist interventions as part of the patient's healthcare team, improved diabetes therapeutic outcomes, substantiating the important role of pharmacist in team-based diabetes management. The clinical pharmacy team at Community Health Alliance, we were the first FQHC in Nevada to obtain a collaborative practice agreement. A collaborative practice agreement is where the pharmacist and providers establish written guidelines and protocols that allow the pharmacists to initiate, modify, or continue drug therapy for a specific patient. The process in order to get a collaborative practice agreement is once you have your written protocols established with your provider team, then you would submit them to the Nevada State Board of Pharmacy. This is something that needs to be done annually once it's approved. The first year that we did this, it took about 6 to 8 months of back and forth in changing our protocols based off the state board's recommendations to make sure that they were in alliance with what they were looking for. So it took almost a year, I think, before we finally got our first collaborative practice approved. So it's definitely a lengthy process. And then you have to make sure that you get it renewed every year by having the providers sign the paperwork every year. We have collaborative practices in diabetes, hypertension, anticoagulation, and polypharmacy.
All right, so in regards to what we do, so Jen did an awesome job explaining what clinical pharmacist does. So here at CHA, we practice based off CMM, which is comprehensive medication management. So comprehensive medication management is a process that ensures that every medication a patient is taking, either it be prescription or over-the-counter medications, are individually evaluated, and we make sure that each medication has an appropriate indication. So is there an appropriate disease state the patient has that each medication is for? Is the medication safe? Is the medication effective? Is the patient adherent to the medication? And is there appropriate follow-up? So those are the main guidelines that we go off of when we're seeing patients face-to-face in regards to comprehensive medication management. Okay, so our delivery model. So patients who are between the ages of 18 and 75 with type 2 diabetes or even type 1 diabetes with an A1C greater than 9 are referred to our clinical pharmacy program for diabetes management. During the first initial visit, we mainly just sit down with the patient, go through all your meds, make sure, again, every medication is safe, effective, has an appropriate indication. we try to resolve any barriers at this point. So at this time, we ask patients, what do you think is the problem, here, what can we do to help you? So the initial visit, we spend mainly, doing like a solid medication reconciliation, try to identify barriers, and we set goals. And follow-up appointments, we spend more time, now changing medications as needed, ordering labs. We try to see how the goals that we set in the prior appointments are going. And this is a circle, and this is something that's continuous flowing process until the patient is at goal. And once the patient is at goal, usually at 2 different A1C checks, then we refer the patient back to their primary care provider. During this process too, we do, if there's some things that are a little bit beyond our scope, for example, behavioral health, if we notice that there is a behavioral health component that is making the patient not adherent to their medications, we will we'll refer, do a warm handoff to our behavioral health team to try to, to help, to work with us to help break those social barriers. But again, it's a flowing process, and we just repeat the same process until we're at goal. All right, so how can we help? So here at CHA, what our pharmacists do, how we can help our providers. We utilize guideline-oriented approach for medication initiations. We help decrease cardiovascular events. So we will identify if a patient, for example, has a history of an MI or a CVA, we will make sure we're initiating medications that have shown to reduce 3-point MACE, like Jardiance, Invokana, Victoza, Ozempic, Trulicity, or some of the other medications out there that have shown to reduce cardiovascular events. We help decrease cardiovascular risk. So while we're with patients, we'll identify if they're in an ACE or an ARB, if they have a history of microalbuminuria, or we make sure they're on appropriate statin therapy if they're over the age of 40. So, so we help decrease cardiovascular events and also help reduce the risk. So we order routine labs. If we identify a patient hasn't had labs routinely, we'll help the PCP out. We'll order CMP, CBCs, lipid panel, A1Cs, TSH, whatever we've seen in the past that the providers have ordered in regards to patients' health, and they have an upcoming appointment with their provider. We will make sure the patient has those upcoming labs to help the provider. We help adjust doses based off of renal function. So if we identify, patients' eGFR is starting to trend down, we will step in and we'll make those changes for the patient's safety. Also cost. So if prescriptions are too expensive for patients, we help modify whatever prescriptions to their therapeutic alternative that is more affordable. So we ensure appropriate follow-up with PCP. Sometimes we notice that patients keep coming to the clinical pharmacy team, but they are not following up with your PCP. So we would ensure that, make sure you're scheduling up with your provider. Make sure, have you seen your cardiologist, this year or in the past 6 months? Make sure, you're scheduling with these people at an appropriate, timely manner. So we ensure medications are received and started in a timely manner. So, we try to initiate, medication. For example, if we're starting a patient on an injectable medication, we will try to do the first shot in office, just to make sure the patient feels comfortable and the patient is able to start the medication in a timely manner, rather than we talk about it and they push it off due to a fear of needle or fear of using it. So we try to make sure that things are started in a timely manner with patients. We can help with smoking cessation. We help store and provide samples. If some medications require prior authorizations, we could get the patient samples and we could get those medications started, given the time it's going to take for prior authorization. So we're not missing that time with the patient in there, that we could get the medication started. We also help with prior authorization. So our pharmacy team, we do prior authorizations for our providers here. And the pharmacist will help one of our techs who does the prior authorizations. If there's any complicated prior authorization, instead of sending it back to the PCP, the pharmacist will take control of those complicated prior authorizations and help out. We also help with patient assistance programs. So some patients who are uninsured, undocumented, some of the patient assistance programs with the drug manufacturers are really good about that. And that's an avenue that we've seen that does help some patients who have, zero income and are not on Medicaid. And they could get like a year supply of some of these medications through patient assistance programs. All right, so how did we get started in all of this? So we noticed that there was a huge demand. A lot of our providers they were always calling our pharmacy, asking questions, asking for help, asking for us to come into the clinic to talk to some patients. So we joined this team. It's called A3. So A3 stands for ASHP, APEXUS, and the Alliance of Integrated Medication Management, AIM. So the A3 Collaborative is a national learning experience designed to help healthcare providers and organizations make CMM a part of their plan. So when you join, you do have a learning coach, and that learning coach, makes you accountable for your barriers. So we try to identify barriers that your clinic has. They make you accountable in regards to working towards breaking those barriers. You share ideas with other clinical pharmacists and other clinical teams around the U.S. who struggle with different things. And instead of trying to reinvent the wheel on your end, there might be someone else in a different state who was easily able to figure something out, and you just bounce ideas back and forth. And that was somewhat how we were able to get this process started and get the program going. All right. So while we worked with A3, we worked with them for 2 years. This was our most recent data that we collected. So our target population was 100 patients with an A1C greater than 9. And our baseline was 0% of these patients were going to be our goal. And the reason why we chose an A1C of 9 is based off of UDS measures, being as an FQHC. We're going to identify this 100 patients from November 1st to for about 3 months. And then we'll monitor them for an additional 6 months. And our A1C goal was less than 9, again, for UDS measures. All right, so we were able to identify and see 100 patients with an A1C greater than 9 within those 3 months. And our bold aim was to get 60% of these patients to less than 9. That was our goal. So by the 9-month mark, we were able to get 52 patients at goal. And, and that is, 52% of our goal is 87%. So we're able to get, a significant amount of, I guess, half of those patients to goal. But if you look at the dates there, that was kind of when COVID, really hit hard, right around March, April. So patients stopped coming to clinic. Things were telephonic. We couldn't get patients to get A1Cs. So once we were able to, we just stopped right at September 1st with whatever data we had. So deep down, I do believe that we definitely hit more than 52%. We just did not have those A1Cs on hand because patients could not go to labs to get their A1Cs. We were doing everything telephonic. Patients weren't allowed in clinic. So most of these data collected were via labs and phone calls. Okay. So something that we noticed and then we do fight with every day is earning the trust. We do need to earn the trust of our providers for them to refer patients to us. So some ways that we were able to earn our providers' trust were by attending daily huddles. So when they huddle up to talk about patients, we try to be involved, giving them some ideas here and there with some of their patients. We help our providers with prior authorizations, giving them time, to work on other things. We help switch medications to therapeutic alternatives, without putting that back on them. We just make the changes and send them a message saying, hey, we switched from Levemir to Lantus based off, cost or based off of insurance changes. We help our providers meet UDS metrics, which is great for them also. So for example, like with our data, we just saw, those are 50 patients who were not our goal, and now they're a goal based off UDS measures. And we give our providers like monthly drug discussions with whatever guideline changes or new drugs or anything that's new and out there. We try to have monthly discussions with our providers if possible. So we had a provider satisfaction survey, and then this is some actual comments from our medical providers. Hire more pharmacists at all locations. Warm handoff to pharmacists at all locations. I love co-visits, saves time and improves cohesiveness between providers and patients. Not only the providers do we need to earn to trust, but patients also. We need patients to trust us to come into their appointments. And some ways that we've identified that make our patients trust us is breaking those barriers, because they came in for a reason, and we try to identify what barrier is that. Is it medication costs? Could we help with samples? Could we help with the patient assistance programs? Is it adherence? Could it be as easy as giving them a pill box to put their medications in, or just a one-on-one glucometer training? If it's something that's social, if we identify a social barrier, we refer them to our behavioral health specialist, or we recommend some resources in town. Is it transportation? We start when COVID hit pretty hard. We started a drug delivery system within our pharmacy. So patients who could not leave their homes, or patients who could not afford transport, we were able to start a drug delivery system, take the medications to their homes to help improve and continue their medication adherence, and in turn to improve overall health outcomes. And required immunizations. If there's anything we need, we identify, we try to give it to them if possible. Not only providers or patients, so we need to earn the trust of the entire team. The call center, they help with our scheduling, our IT department. They help with our laptops. They help with our EMR. They help with our templates. Our front desk, they take the calls. They walk in. They let us know, if this patient is outside, and and they know that we love our patients, and they love our patients too. So this earning the trust of the entire clinical team is very vital and very important, and it has worked in our favor a lot, because we worked hard to earn some of their trust, and they will help us if we need. Okay, so some of the challenges we're facing. We're desiring a full-time clinical pharmacy program. So I know we've talked about all of this, but it is not still 100% where we want it to be. So right now, staffing. So we're currently seeing patients all day on Mondays, and then Tuesdays through Thursdays half day. And the biggest issue, the biggest kickback that we've gotten from our senior leadership is reimbursement. So we cannot directly bill for these services as an FQHC. We don't have the avenues to bill as compared to some of the other facilities, like in a hospital, they could bill a facility fee or an incident to codes, but within an FQHC, we're limited to bill some specific codes that other clinical pharmacy programs could bill for. So with us not being full time, we have currently like a 4 to 6 wait time between patients. So that's a big challenge, for us, especially with medication changes. Our patient population. So being an FQHC again, health literacy is an issue. Patients are uninsured. Transportation is an issue. Provider status, like Jen mentioned, we don't have provider status to bill. So that makes things, difficult with trying to show direct revenue. And knowledge of what we do. Sometimes I've heard some patients say, I have a pharmacist at CVS. Why do I need to come see another pharmacist here? They don't know what a clinical pharmacy does, and a clinical pharmacist does. And this is why we're also having this presentation to throw the word out there to spread the great news of the proof of pharmacists, within FQHCs and within clinics. Okay, some breakthroughs we've had. We have a new referral process. In the past, we had providers just place patients on the schedule, but now with the referral process, we could track things a little better. So with our new referral process, I could see patients who have future appointments all in one pool. So within that 4 to 6 wait time, I could go through this pool and see a patient who's new, who has an A1C greater than 14. So instead of waiting to see that patient in 4 to 6 weeks, I can call them and be like, hey, talk with them over the phone very quickly, start whatever medication we need at that time. And then at that 4 to 6 point for the first appointment, it'll be more of a follow-up, because we've started them on insulin, we've gotten them a glucometer, we've switched their medications around. So that new referral process has been really nice. utilizing our 340B pharmacy. So that's always a breakthrough, because some patients who don't know the benefit of 340B, it could just be as easy as switching your pharmacies from CVS, Walgreens to our pharmacy. And based off our 340B costs, they're paying very little for their medications, whereas we're paying a lot at a different pharmacy. Our medication delivery system has been a huge breakthrough, and utilizing telephone visits to decrease wait time. So again, if we're starting a new patient on insulin and we can't really wait 4 weeks to see him again, we could call him up, in 2 days, and then have a conversation over the phone. And we're also trying to incorporate continuous glucose monitors to help improve patient outcomes and satisfaction. As far as billing, so we've tried different things, again, because we can't bill directly as an FQHC. We tried co-visit billing, which some, during our A3 time, there were clinics that used co-visit billing and were successful with it. And we tried it too. And co-visit billing is when, while we're seeing a patient, the patient's PCP comes in and it counts as a meaningful visit, and they could bill their regular doctor appointments for that visit with us. But we tried that, and it did not work, because our providers were busy by themselves, trying to have them come in while they're backed up 2-3 patients to come see our patient while we're in there with them. It did not work for our providers. So that's one thing that we tried and did not succeed for us. So we currently are going through the avenue of becoming, we became approved to be a diabetes education accreditation program. So with this approval and with this certification, we can bill Medicare directly for our diabetes service. Either it be we're an FQHC or not, we could bill Medicare directly. And this year, the G0108 code, that's the code for the DSMT service, and it's $52.50 for a 30-minute visit. That was a lengthy process to get that approval, but we were able to successfully get approved, and hopefully we could start showing some direct revenue. We do show indirect revenue. When we see patients, and refer them to the pharmacy, we do get some indirect revenue from that, but we still cannot show direct revenue from billing for these services. And also MTMs. We're trying to push our MTM program to get some revenue that way. All right, so our future goals. So like Jen said earlier too, some of these things take a very long process, from our collaborative practice to our diabetes education accreditation. It takes a long time. So we've kind of, we've agreed that, some of these things cannot happen overnight, small steps, but we just got to keep pushing. So our first small step is to try to become a full-time service to serve our patients. Now that we're able to bill for our services, our plan is to create a business plan to sit down with our C-suite, our CMO, CFO, CEO, to go over this and explain, okay, now we could bill for our service. We need to help our patients out by opening up our schedules, and hire hopefully a second pharmacist to also help with this, to help improve overall patient outcomes. Any questions?
Yeah, thank you so much for presenting. Any questions for Natochi and Jennifer?
And not only questions, we're also open to advice from some of the other FQHCs out there. If anyone has any awesome ideas, any awesome advice for us, we'll be very, very happy to listen in. And because again, we're not 100%. We're trying to strive. We're trying to push. We're trying to grow, increase. So we're very open to not only questions but advice and or anything.
You can raise your hands using the raise hand button at the bottom, and I can make sure to unmute you. You can ask a question.
Yeah, it looks like we have one question from Andrew from Canyonlands. Can you explain where you got your CPA template from, or how you started that process?
Yeah, so we were working with another clinical pharmacist at one of the local hospitals where they do, they have an anticoagulation program. So we kind of used their template. And then we integrated the steps that we use in our healthcare system here, as far as rooming the patient, having the patient check in, how they sign for their consent forms, what steps we have to utilize for a referral within our EMR from our providers to get them over to us, what the follow-up looks like on the back end. So it's helpful to have a template, but it's very, very individualized based off of your healthcare setting because there's so many different pieces that you need to integrate that are very clinic specific. So, and then trying to incorporate and interpret what the law says and how we interpret that versus how the state board interprets that was definitely, that was our biggest struggle. So there were a lot of edits, like I said, that went back and forth where we were missing small little pieces and we would have to fix it, resubmit it, fix it, resubmit it. And so it was quite a lengthy process, but once you have them, it's definitely easy as long as you're not making any changes. This year, because we did get a new EMR between last year and this year, when we submitted it, we notified them and highlighted the changes that we did make. But they were appreciative of that and they signed us off right away. So maintaining is definitely easier than getting it. Anything to add to that?
No, I think that's right.
See, I have a couple questions too that I want to ask. If you were to go back to the developmental stages of the clinical pharmacy program, what would you have done differently? And what would you provide or have leadership know about clinical pharmacy programs when trying to convince another FQHC to start the program?
Trying to think here.
I think if we could go back and start it all over again, I think we should have had a bigger ask from our senior leadership and said, you know, I think the way that it started, we were very modest in what we were asking for because we weren't sure how successful it was going to be and how well it would be perceived by our providers. We just noticed because Nato and I used to work on the bench together in the retail pharmacy, and we were hitting this breaking point to where it was like, we are having a hard time keeping up with the retail portion of things because we get interrupted so often. So we could make a case to senior leadership that we needed at least, you know, a part-time position where we would sit one-on-one with patients. And we really should have asked for full-time to start off with. We were very naive in the fact that we thought we could handle that much more. And with the referral system, this is new this year. Like I said, we switched our EMR system. And I think that we were kind of blinded to the fact of how many providers are referring to us. I think there's, how many are in the queue right now?
Yeah, so we have about 200. I mean, this is from when we just started this new referral process, which was like in February.
Right? Yeah.
And already have like 200 referrals and about 60 pending, like patients who have not yet seen but are already scheduled. And that was just starting count from February, not really counting some of those patients who we had been seeing prior to the new EMR change, who don't have that referral in there yet, but they were just like a reschedule. So yeah, I 100% agree with Jen. If we had known from the start, it would have been, let's start with a full schedule rather than start with a mild schedule, and because now we're asking for that full schedule, and it's difficult. So I 100% agree with Jen on that one.
Yes, thank you both. And we have some comments in the chat box too. So one, Cortland said, thank you for the presentation. Someone new to my role as a CMO, the information certainly helped me better understand the potential role of clinical pharmacies within FQHC. So again, thank you both. And Andrew Canyonlands mentioned, this great presentation. Just a comment. Another thing that we have done in my organization is to try to have a pharmacy involvement in hepatitis C management. The revenue stream has been able to justify the clinical non-revenue part of the team.
That's, I know, we have often talked about that. It's a great suggestion, and it's something that we really would like to branch into eventually.
And I'm sorry, who asked that question?
No, it's a suggestion.
A suggestion.
Andrew, right?
Yeah.
Is it- Okay.
Thank you. Any other questions for Nitochi and Jennifer?
Looks like we have another question, Rima.
Oh, we do? Okay.
How should we go about offering our service to a clinic that may not have necessarily have the funds to have us?
So I would start by, just involving yourself, if you've earned the trust of your providers, something that we've looked at and something that we've tracked in the past was some kind of indirect revenue to show the actual impact, like meeting UDS measures. So, being an FQHC, the clinic will get some kind of, when you meet your UDS metrics, so if you're able to show how you're helping your providers meet some of those UDS metrics and getting some indirect revenue from that, that could be a way to show, even if it's not direct, it's indirect. And which is something that we also face here. So we show indirect revenue from the prescriptions that we are sending to our pharmacy, which is significant. And as far as helping our providers meet UDS metrics.
And it's a good patient touch. The patients love having us hold them accountable, and they like having more than one contact within the organization. They know that they can walk into any of our retail pharmacies and talk to one of our pharmacists, and they can look up the notes and see what we've done within the clinic as well as with their providers. So they like that there is a direct communication to somebody that is part of their healthcare team. And I think that gets so much patient trust. And it holds them accountable. So.
And one thing I'll just recommend is keeping track and just getting some data. If you could get data on some of the patients that, you're helping so far, and patients have like success stories saying, my gosh, I spoke to our pharmacist and, this happened, or some stories from your medical provider saying, gosh, I worked with a pharmacist on this and this happened, so even if it's difficult to show like revenue, just some of those outcomes that are life-changing could be enough to move things for you.
Thank you all for the questions and the great conversation too after your training. And looks like Dr. Barton also has as one more comment, our clinical pharmacists are an incredible resource for our patients and for our clinicians.
Thanks, Dr. B.
Thank you, Dr. B.
It's wonderful. Okay, great. So again, thank you everyone for attending today's session. If you have any further questions, you can contact me at rnaik@nvpca.org. Once you leave today's webinar, you'll receive a survey for the presentation, and we would appreciate it if you have time to complete it to provide us feedback. Again, thank you so much for joining us today. And on behalf of the Nevada Primary Care Association, have a wonderful day.
Thank you.
Thank you.